Okay, hello everyone. I see the first question in there. So yes, hot nodules are likely benign because they are functioning. They're more likely just to be thyroid tissue itself, just enlarged thyroid tissue. It's that when it's cold, it's non-functioning, most likely a cancerous cell that's not going to function like normal thyroid tissue. Therefore, it's no uptake to iodine. Okay, dexamethasone suppression test. Okay, so there are two doses that we give. We give a low dose and we give a high dose. My sound okay. Is that better? Let me know. So there's a low dose and a high dose. When we give the low dose with normal people, we get suppression of cortisol. So cortisol goes down because at the normal low levels, there's enough receptors in the pituitary gland to shut off production of ACTH, therefore cortisol levels drop. So there's no reason to do the high one because we already have suppression. If they have Cushing's disease, Cushing's disease means it's a problem with the pituitary gland itself. So remember that. Cushing's syndrome is just any form of hypercortisolism, but Cushing's disease is the actual disease of the pituitary gland itself. At low levels, we have no suppression of cortisol. At high doses, we do have suppression because at high doses of cortisol, there is enough receptors left for cortisol on the pituitary gland to shut it down. So at high doses, there is some suppression left because there are receptors for cortisol to shut production down. If we suspect they have an ectopic source, so a source outside of the pituitary, at low doses of dexamethasone, we have no suppression. And actually, let me just erase this just for keeping the same style. If there's an ectopic source that's pumping out ACTH like crazy, at low dose and high dose, there is no suppression of cortisol. Why? Because this ectopic source, most likely the most common one is the oat cell lung cancer. They don't have the receptors for cortisol to help out with that negative feedback. When we have our normal negative feedback, the HPA axis, pituitary gland and hypothalamus have receptors for cortisol so that they know how much cortisol is floating around in the blood. The ectopic sources have no purpose in that, so therefore they have no receptors. It just happens, they just happen to be secreting ACTH. So with the dexamethasone suppression test at low and high doses, there's no suppression of cortisol at all, but they have high cortisol. Most likely it's going to be an ectopic source, and now you have to do a full body PET scan or a CT scan, mainly of the chest, just to see if there's any cancer cells or any nodules anywhere that would lead you to believe they had that type of cancer. So hopefully that answers your question about next methicillin suppression test. Next question is about latent DM versus type 1 diabetes and type 2. It's all based off of history. So with type 1, there's the juvenile onset, young child. That's when it usually kicks in. That's why it used to be called juvenile diabetes, but then too many other kids started getting type 2 diabetes, so they had to differentiate back again and call it type 1 versus type 2 because of the childhood obesity going up. They had to rename it. So that's why you don't see juvenile diabetes anymore. But type 1 diabetes can be juvenile onset, or they're going to be the latent autoimmune one that happens later in life. The key differences is one, in type 1 diabetes, whether it's early onset or late onset, they're going to have a high A1C, and they're not going to be making any insulin. So once you draw their blood, you'll see that their insulin levels are low. A1C is high. You do a glucose tolerance test, and it just keeps going up and up and up. There's no suppression of glucose because of the... so it's all based off of history. And type 2 obviously is going to have some insulin resistance in the tissues. Type 1 will not have that. Vagotomy will involve all motility disorders. It can do both. We talk about just autonomic dysfunction mainly with the gastroparesis, with the diabetes. Dumping syndrome is usually like a post-surgical. I mean, they both can be. I mean, you're dealing with nerves here, and remember, you have like paralytic ileus after surgery where the bowels don't move very well. So it all depends on presentation. Are they having profuse diarrhea, or are they having constipation? You know, you're looking at motility problems. So when it comes to all those things. Goiter enlargement is symmetrical, but for our non-toxic and toxic nodular goiters, will we differentiate that from the other diseases based on nodules being there? Yeah, there'll be history there. Is it fixed nodule? Remember, with toxic ones, they're going to be painful. You know, there'll be some history there. I went through all those. I told you, remember, is this painful? Is this painless? Is it a fixed nodule? Are they rubbery? So those differentiations. Next one is central DI versus nephrogenic. Let's blow this up, make some space here. Okay, so we have our hypothalamus to our pituitary gland. Pituitary gland is going to secrete ADH, and in a normal environment, again, this ADH is going to go all the way down to the kidney and act at the distal convoluted tubule colon collecting duct to cause increased water reabsorption. So in central DI, the problem is with the pituitary gland. The pituitary gland does not even make any ADH. So there's no ADH being made. So we give them vasopressin, and we see what happens to the urine output. Obviously, if they are sensitive to ADH, urine output goes down because they're going to be antidiuretic and they're going to be sensitive to it, and they'll have some reduction in urine output. But in central DI, the kidneys are still responsive. Now, let's do the other side. Let's do nephrogenic. Nephrogenic DI, the problem is right there. You lack the V2 receptors in the kidney, or there's damage to them. So ADH will never work at the kidneys because the kidney level is where the problem is for nephrogenic. So they do have ADH. Their pituitary gland still works. It's still pushing it out. The problem is the kidneys will not respond to it. So when you give this patient ADH, nothing happens. So there's no response when you give them the ADH because the kidneys are not responding to it anyway. They do have it in their blood, but just that those V2 receptors don't work. So I hope that one is sufficient for that one. Next one. Hyperaldosteronism. There is polyuria and polydipsia due to ADH. Okay, let me pull up that slide here. You know what slide that was? Just let me know what slide it was. I'll go back to it. Pertinent lab findings we would see with pheochromocytoma, aside from elevation of epi, norepi, or both of them. You will have both elevated. Also, I didn't go into too detail, but one of the things you will see is in a 24-hour urine collection, increased VMA, that vanilla mandelic acid, which is part of the byproduct of the metabolism of the epi and norepi. But the big thing is, and labs, it's going to be elevated norepi and epi because of the tumor that pushes them out. What labs we expect to see in Hashimoto's? Primary hypothyroid labs, yes, but the key thing with Hashimoto's, remember, they have 3 types of autoantibodies. They have the anti-TSH, which is going to sit in the receptor for TSH and turn off the thyroid gland. Conversely, Graves has the TSH receptor antibody that will sit in the same receptor and turn it on. So make sure you know the differences between those two. The other one they're going to have anti-TPO, thyroid peroxidase, going to have the antibodies to that, shutting that off, and anti-TG for the thyroglobulin for the storage. Oh, okay. So Noel, so the question that you had about the ADH. So when we have excess aldosterone, let's see what else. The ADH is still, all it was trying to say is that the ADH is still working, and that causes polydipsia. Like thinking if ADH is still stimulating thirst, you're thinking that you're dehydrated, so you're going to keep drinking water. Okay. Hormones are affected with CAH and Addison's disease. So with they're deficient in this 21 alpha hydroxylase enzyme. They don't have it. So when we're making our hormones, we have our aldosterone, we have our cortisol, and we have our androgens. Cholesterol is the main ingredient that starts the whole thing off. You need this enzyme to make that and to make that. When you don't have it, all this cholesterol follows this pathway. I'm going to put a big arrow, and it all falls into the androgens. So that's why you have low aldosterone, low cortisol, and high androgens with congenital adrenal hyperplasia with a 21 alpha hydroxylase. Okay, so that's that one. Okay. Let me go to that one. Elevated glucagon with type 2. Okay. Glucagon. So remember with the islet, just color that a little bit. So remember the way that it's formed. All the alpha cells, these alpha cells out here that I just drew in, are glucagon cells. The beta cells, drawing circles on the inside, are on the inside. The blood supply starts in the middle and works its way out. As they become, and they burn out their pancreas, they burn out the beta cells, there's no negative opposition of insulin. Insulin, as it comes down and it bathes over, has a negative inhibition on glucagon cells, so it turns it off. Now we're not there anymore. So glucagon kind of goes unopposed, which also further makes your blood sugar go up and make it worse. The next one is myxedema. Okay. So myxedema is just any type of hypothyroidism. Pretibial myxedema is just referring to the actual skin condition of the thickened skin on the anterior lower leg. It does associate with Graves' disease, which obviously is hyperthyroidism, which is kind of where the confusion can come in. But the Jeopardy that was posted had all that. Okay, let me post the other one. That's not on this exam. The neuro is not on this exam. That may have been from an old one. Let me change that right now, actually. Because I have the case studies up. We can go over that when you guys are slow with the questions. But let me put the right one up. Okay, so the right case study should be there. Okay, let me know if you have any issues with that. And myxedema coma. Let me go to that one. That is due to severe hypothyroidism. So it's like the opposite of thyroid storm. Thyroid storm is massive amounts of T3, T4. All that colloid, all that stored thyroid hormone just gets dumped into circulation real fast. You can result in a coma with this as well. So they both will present with a coma. One's going to have very, very, very low thyroid hormone. One's going to have very, very, very high thyroid hormone. Thyroid storm is very, very high. Myxedema coma, very low T3, T4. Next one, secretory diarrhea and why it occurs when secretagogues maintain elevated rates of fluid transport from. So the cholera, it just turns. So remember, in secretory diarrhea, something is turning on the cells to dump the fluid into the lumen. Cholera turns on those cells to dump water into it. Secretagogues are anything that helps secrete something. So the cholera is a secretagogue that turns it on. So that is what cholera does. It's a secretory diarrhea. It's secreting something in there. That's why with a secretory diarrhea, fasting does not help, because the cholera, for example, is still there. It's not going anywhere. With osmotic diarrhea, it's usually due to something that you're eating. So that's why when you fast, you're not eating that food that's causing you to have the osmotic diarrhea, and the diarrhea goes away. With the secretory, that bacteria, the virus, bug is still there, turning on those fluid jets and turning it all going inside the lumen and causing the diarrhea. The secondary answer choice for the secondary hypothyroidism was probably a miskey on that Kahoot. So remember, let's go through real fast. For primary hypo, they're going to have let's do it this way. TSH, T4, and T3. We have primary, we'll have secondary, we'll do tertiary, and let's do poor conversion. Okay, let's change the color. Primary hypothyroidism, the problem was with the thyroid gland itself, so we're not going to be producing T4, we're not going to be producing T3 because the primary problem is the gland itself. Because now there is no negative feedback, to the hypothalamus. To the pituitary gland. Scratch all that. Primary hypothyroidism is a problem with the thyroid gland itself. Thyroid gland will not do anything, therefore there's no negative feedback to the pituitary gland. So the pituitary gland will continue to pump out TSH to try and get the thyroid gland to do something. In secondary hypothyroidism, the problem is with the pituitary gland. So the pituitary gland is not doing anything. You have a thyrotroph tumor, you're not making any TSH. Therefore, you will have low TSH, but you will also have low thyroid hormone as well. Tertiary hypothyroidism. Now we're dealing with the hypothalamus. I didn't include this hormone, but if I were to explain the problem was at the hypothalamus, I'd have to include TRH as well. And in this case, TRH is going to be low, therefore TSH is low, therefore your thyroid levels are low as well. But I would have to give you the TRH in there to show you that the hypothalamus is damaged and that is not releasing any TRH, therefore the pituitary is not being stimulated to make any TSH. So that's an example of that one. The last one is the poor conversion. We're going to have normal TSH, normal T4, but low T3. We're making the hormone. There's enough T4 to provide the negative feedback. Remember, we have more T4 production than we do T3 production. So T4 is going to be the one mainly doing that negative feedback, but we convert the T4 to the more active form as time goes on in a response that's controlled. But when we have poor conversion, T3 does not match the appropriate level. I will add into this section as well one more for hyperthyroidism. In hyperthyroidism, we have low TSH, but high levels of T4 and T3. So our normal inhibition is still here. So we're inhibiting TSH. We don't need any more thyroid hormone, but we're still producing a ton of thyroid hormone, and that shoots up real fast. So I hope that answers the question with regards to different types of hypothyroidism. Okay. I'm going to switch over to the PowerPoint. We'll start going through these case studies until there's another question. Okay. So first one, a 32-year-old woman comes to the PCP with persistent burning sensation in her chest and upper abdomen. Worse at night and when she lies down after meals. Tried drinking hot cocoa to help her sleep. She's a smoker and relies on benzos for insomnia. Sour taste in her mouth. Every morning. Physical exam, unremarkable. And what is your most likely diagnosis? Again, it's going to be just reflux esophagitis for this one. What lifestyle modifications do you suggest for this patient? Well, lying down after eating is not a good thing. Hot cocoa, we know chocolate can make your GERD worse. Smoking, benzos, all those things, weaken the lower esophageal sphincter, make the GERD worse. Sour taste is from the acid coming up. Complications of GERD, remember you can get strictures, dysphagia, it's going to start being a problem swallowing with these patients. Perforation or hemorrhage, And then you get worse as you keep going. Hoarseness because of the current reflux irritating your vocal cords. Worst case scenario, aspiration pneumonia, and obviously Barrett's esophagus. Next case, 38-year-old homeless male, type 1 diabetes, comes in with right lower extremity cellulitis, just a skin infection. Prescribed oral antibiotic for the past week, not noticed any improvement. He gets his insulin at a free clinic, takes it when he remembers. For the past 2 days, he's complained of intermittent fevers and chills, nausea with poor oral intake, and erythema spreading proximally over the right leg. Obviously, that's due to the cellulitis. Markedly confused, and friend calls 911. Emergency room, oriented only to his name. So we have altered mental status, tachypnic, breathing deep, febrile. He's normotensive, heart rate is at 112 though. On exam, he's delirious, disheveled male with a fruity breath odor. So remember we talked about that. That's the ketone we're breathing off. And still has obviously the right lower extremity cellulitis. Chemistries, glucose of 488, potassium 3.7, sodium 132. And obviously urine dipstick's going to have a ton of ketones in there. So what's your diagnosis? Obviously we have a type 1 diabetic who is coming in with altered mental status. This was probably precipitated about due to the infection that he had. And because he has no insulin, he's making ketones. So diagnosis is DKA, diabetic ketoacidosis. And the precipitants in this patient, obviously lack of insulin that you see with type 1 diabetics. And ketosis was precipitated by the acute infection of the cellulitis, caused the release of all the glucocorticoids and other stress-related hormone release, which ultimately increases that blood glucose. And that's where all the deleterious effects come in. Next case, we have a 30-year-old woman comes to the emergency department after sideswiping a parked car. Never saw the car until after she hit it. Denies any trauma to herself, but complains of a headache. She said that she's had a headache every day for the last 3 months. And this one is similar to the other headaches. Wait a minute, which one is this? Okay. So she has a headache, wakes her up from sleep. No significant medical history, no medications, no alcohol, drug use. Irregular menses, but no other complaints. Physical exam, normal for vital signs. Neural exam, notable for bitemporal hemianopia. Breast exam, galactorrhea is present, but no masses. And remainder of exam is unremarkable. So this is a pituitary adenoma. She's having bitemporal hemianopia. She's getting headaches, irregular menses, galactorrhea, so prolactinoma. So pathophysiology behind the bitemporal hemianopia, mass effect from that adenoma creates that bitemporal hemianopia. Optic tract is directly above that pituitary gland. Below the pituitary gland is the sella turcica. So there's bone there, so only it can grow is up and hits that optic tract. Irregular menses, galactorrhea, part of the prolactin excess from the tumor. Next case, we have a 40-year-old woman with worsening right upper quadrant pain. Pain began after eating pizza for dinner 2 days ago. Sharp stabbing sensation right under the right ribs. Felt ill, some slight increases, low-grade fever. Denies any nausea or vomiting. So physical exam, obese woman, low-grade fever, right upper quadrant tenderness. Abdominal ultrasound shows a 2 centimeter gallstone lodged in the cystic duct with swelling of the gallbladder, obviously, and thickening of the gallbladder wall. So what's going on here? She has cholelithiasis. Why? Supersaturation of bile. It comes out of solution and precipitates out, causing these stones to form. Or it could be due to loss of gallbladder wall motility, so the bile sits in the gallbladder longer, therefore more opportunity to precipitate out. Or the increased presence of estrogens, which is why cholelithiasis is more common in females. The 4Fs, fit, fat, 40, and fertile. Or 40 female, fat, and fertile. And the prostaglandins, or gallbladder motility stasis, where it just sits there. So those are what causes the cholelithiasis to form. Now, what's the link between cholelithiasis and cholecystitis? It's the lysolecithin that is normally found in the walls of the gallbladder. When you have the stones scrape the walls of the gallbladder, causing irritation, and it converts the lecithin to the lysolecithin, and that precipitates the inflammation to the wall and causes the inflammation, and that is your acute cholecystitis. So that's called lysolecithin. Local complications can occur from gallbladder disease. If the cystic duct is blocked, you get your acute or chronic cholecystitis. If the stone comes out of the gallbladder and now lodges itself in the common bile duct, you'll have obstructive jaundice, so it'll come out, they'll be yellow. The sclera will be yellow, icteric sclera. If it blocks the sphincter of Oddi, you can get pancreatitis because now the pancreas can't drain, and the pancreatic juices will back up into the pancreas, causing pancreatic inflammation and pancreatitis. Or you can get cholangitis as well. So these are the complications that occur with gallbladder disease. Next one, on a cruise ship sailing to the Caribbean, number of passengers develop acute onset. I'll get with your question in a second. Let's go back to it. So for this question to be just cholelithiasis, they use, if they're coming in, so cholelithiasis by itself, you for the majority of the time, you're going to be asymptomatic. It's usually seen by accident. Oh, you got gallstones. You've got cholelithiasis. You have gallstones. They're there, but they're not causing any problems. In this case, because they are having a lot of symptoms, so it does have the gallstone. So in this case, I wouldn't put an answer to be cholelithiasis or cholecystitis. That would be too confusing. Cholelithiasis is a diagnosis that is second, or you could say they have acute cholecystitis secondary to cholelithiasis, if that's the case. So you can find gallstones on routine exam. They'll have cholelithiasis. If they are coming with all of these complaints, now it's usually a cholecystitis because now you're having some complaints with it. So I should change that for next year. Okay, acute onset, non-bloody diarrhea. Local excursion to a small Mexican village where they sample local cuisine. Deny any fever, nausea, vomiting. Will report 8 to 10 loose watery stools per day, despite significant anorexia. So they're not eating, but they're still having the diarrhea. So think about this. Something is causing them to still have diarrhea, but they're not eating anything. It's something turned everything on. Fecal leucites don't appear in the stool of the samples of affected passengers. E. coli infection is identified during an outbreak investigation. Symptoms are self-limited in most passengers, improving after 48 hours. Usually that's what happens. Self-limiting. Just kind of try and hydrate yourself as best as possible. Do what you can and go through it. So what's the mechanism and what clinical clue? Secretory diarrhea, hypersecretion of fluid, electrolytes in the small intestine, no bloody stool as well, but also the fact that it remains while they're fasting. Yeah, there it is. Diarrhea despite poor PO intake. What groups of patients could the diarrhea have severe consequences? So now we're looking at extremes. Young children, elderly, both extremes, and always immunocompromised. So always kind of keep these three populations together. Young, elderly, immunocompromised. They're the ones who are going to have the most deleterious effects from the severe dehydration. Next one, 25-year-old African-American woman presents with a complaint of rapid weight loss despite a voracious appetite. They're eating like crazy, a ton of calories, but they're not gaining any weight. Physical exam reveals tachycardia, fine, moist skin, symmetrically enlarged thyroid, mild quadricep muscle weakness, fine tremor. They suggest hyperthyroidism. What's the most common cause for hypothyroidism for these patients? And what's the pathophysiology? This is your Graves' disease, and it's the TSHR stimulatory antibody. It sits in the receptor for TSH, where TSH would be a pulsatile, comes in when we need it, but now it just sits in there all the time and keeps that thyroid gland on and pumping out more and more thyroid. So serum TSH and free thyroxine levels are ordered. What results should be anticipated? TSH is low and free T4 should be high. And what's the pathogenesis of the tachy, weight loss, goiter, muscle weakness? Tachy, due to excess thyroid hormone directly acting on our conduction system. That's why with thyroid storm, they go to VT. If they have a defibrillator, it may go off a bunch of times. Elderly patients, new onset atrial fibrillation, think thyroid. Weight loss, we've increased their basal metabolic rate due to the hyperthyroidism. So they're just burning through calories like crazy. The goiter, these antibodies stimulate growth of that thyroid cells. They're producing a ton of thyroid hormone, so they need more cells to do it, and it hypertrophies. Muscle weakness from increased protein catabolism, the muscle wasting due to the excess. Next case, 45-year-old woman complains of fatigue, 30 pounds of weight gain, despite dieting, constipation, and menorrhagia. Physical exam, thyroid is not palpable, skin is cool, dry, and rough. Heart sounds are normal, no murmurs, pulse rate is 50. Rectal pelvics are normal, stool is negative for blood. Clinical findings suggest hypothyroidism, TSH is elevated. Labs are ordered and results should be anticipated. What would you suspect if this was Hashimoto's? So this is where you have, first of all, TSH is high and your free T4, T3 are going to be low because the thyroid itself is not producing any hormone. Antithyroglum antibody, antithyroperoxidase antibody, and obviously don't forget the anti-TSH. Now we have the opposite problem. We have weight gain because with the hypothyroidism, the lack of thyroid hormone, BMR drops. So you're not burning any calories at all and everything just sticks. Constipation, decreased GI motility due to lack of thyroid hormone. Thyroid atrophy occurs, lymphocytic infiltration, and destruction of the thyroid follicles. So you're destroying the tissue, less tissue to make thyroid hormone, And when you have enough tissue loss, then you start getting your clinical hypothyroidism. Before that, you're all subclinical hypothyroidism because you're not having any symptoms of it yet. Skin changes, accumulation of proteoglycans in the dermis, and there's your myxedema. Next case, 74-year-old male with severe osteoarthritis presents to the ED reporting 2 episodes of melena without hematochezia or hematemesis. So just dark stools, no bright red blood in the rectum, and no bright red blood in any vomitus either. He takes 600 milligrams of ibuprofen 3 times a day for his arthritis pain. Physical exam, BP is slightly elevated, pulse is on the high side, but still within normal limits, but on the high side. Epigastrium, minimally tender to palpation. Rectal exam, black tarry stool in the vault, positive for occult blood. So this person is bleeding. Endoscopy shows a 3-centimeter gastric ulcer in the lesser curvature. H. pylori is identified on biopsy. So what are the 2 proposed mechanisms for peptic acid disease? So remember, whenever we're dealing with these types of things, we always have this little seesaw. On one side, we have protective factors. On the other side, we have the harmful ones. The protective ones is the bicarb, prostaglandins, the mucosal layer. Our mucosal defense is there for protection. Harmful ones is obviously anything dealing with to weaken the that mucosal defense. So either we are just pumping out too much acid, or our defense is weak. But it's an environment that's promoting ulcer formation. How may have the patient's NSAID use predispose them to peptic acid disease? So NSAIDs inhibit the synthesis of our mucosal prostaglandins through those different pathways. So the constant ingestion of the ibuprofen for the arthritis caused all of this patient's problems. What role does H. pylori play in the infection with ulcer disease? So remember, H. pylori attaches to the surface of those epithelial cells. It has the flagella to corkscrew its way in and burrow away through that defense of the mucus. In the duodenum, it attaches to any mucosa that has become metaplastic. So it only attaches to these gastric epithelial cells. The duodenum normally never has those cells. It doesn't need those cells. Those cells help prevent for acid erosion. The duodenum shouldn't have that acidic environment. But if the acidic environment is getting into the duodenum repeatedly, causing repeated irritation and inflammation, you may have metaplasia where the cells will change to represent more of that gastric type of cell to resist the acid. Well, that's also now a great host now for H. pylori, and that's how H. pylori infections can get into the duodenal layer or duodenal section of the small intestine and cause duodenal ulcers to form. You have to have the gastric tissue there, which means you've had underlying acid problems for a long time. The H. pylori will then start to secrete urease, which converts the urea in the area to ammonia. And that is like a protective little cloud around the H. pylori to prevent the acid from destroying it. So this acidic, this little cloud, this little alkaline cloud around it from the ammonium is what's causing them to ammonia for that H. pylori to survive. You get increased inflammation, increased acid secretion, further weaken those defenses, and then eventually you get the ulcer formation. Next one, we have a 67-year-old male with type 2 diabetes, seen by his PCP, for frequent nausea, bloating, intermittent diarrhea over the past 2 weeks. The vomiting typically occurs 1 to 2 hours after eating. He states that over the past year, he's become increasingly depressed after the death of his wife and less compliant with his oral hypoglycemic medications. He also reports 6 months of worsening pain in his feet. So obviously he's not being very well controlled. He's not taking his medication, understandable with the depression of his wife or the death of his wife. The worsening pain in his feet, this uncontrolled sugar is now causing peripheral neuropathy to develop. Fasting finger stick shows it fasting glucose of 253. What is the cutoff for if you're having symptoms like diabetes? He's not really having it right now, but he's having symptoms, normally polyuria, polydipsia, polyphagia. And then you have your random glucose. Any random glucose over 200 is one of those criteria for diabetes. So how does the diabetes contribute to the patient's gastroparesis? So obviously he's not moving. The uncontrolled diabetes has caused that autonomic dysfunction. So now we have poor gastric motility. And that's why it's a cause of the gastroparesis. And it's also a consequence because remember now, we're going to have very erratic absorption of glucose, so your sugar levels are going to be all over the place. So inconsistent food absorption creates erratic blood sugar levels. So how does dumping syndrome cause diarrhea? We get a hyperosmolar chyme, that should be a Y, from poorly coordinated gastric pyloric contractions. So we have this hyperosmolar chyme because the food is not staying in the stomach long enough to be diluted and broken down. A lot of it just gets dumped in. Hyperosmolar to balance the equation. All the water gets dumped into the intestinal lumen to try and dilute out that hyperosmolar chyme, causing the diarrhea to form. Fluid sequesters in the intestine, the body attempts to dilute the hyperosmolar content, moves quickly through the small and large intestine, resulting in that explosive diarrhea. Case 10, 44-year-old male complains of episodic palpitations, headache, and diaphoresis. States that come about when he bends over sometimes. BP in the office reads 186/110. So we've got high blood pressure, episodic palpitations, headaches, diaphoresis. Will this patient respond to conventional blood pressure medications? No, because he has a pheochromocytoma. Giving calcium channel blocker is not going to do anything for that patient. You suspect the patient has hypercortisolism. So what test do? Again, we do our dexamethasone suppression test. And so ectopic, no suppression of cortisol with your high or low doses. So that's your ectopic source of hypercortisolism. If it's a pituitary problem, low dose, no suppression. High dose will show some suppression because you still have some responsive cells left. Okay, next case. 36-year-old male presents with polydipsia, polyuria, numbness, and tingling in his hands. He has a high blood pressure of 160/90. Lab results, sodium 139, potassium is 2.9. Potassium is high, sodium is low. You suspect hyperaldosteronism. What are the triggers for primary versus secondary hyperaldosteronism? So before we go to that one, we have high blood pressure, high sodium, low potassium. Why? Because the excess aldosterone is going to cause sodium and water resorption. So the sodium is going to go up in the blood. That water resorption is going to cause the elevated blood pressure. And also the the thing with aldosterone is also going to cause potassium to be dumped into the kidneys. So you have a low potassium. This is what happens with hyperaldosteronism. The opposite effect is true with hypoaldosteronism. Low blood pressure, low sodium, high potassium due to low aldosterone. But this is hyper. What are the causes? The primary problem is an increased aldosterone from another source. There is an ectopic source, something is, or ectopic source, or you have that bilateral adrenal hyperplasia where the adrenal cortex is thickened and you're producing a ton of aldosterone. That is the primary problem, is the aldosterone. You're just producing a ton of aldosterone with no stimulus. In a normal situation, aldosterone is only made with the stimulus through the renin cascade. But in this situation with primary hyperaldosteronism, there is a source of aldosterone that is being produced unopposed. It just keeps coming out. So we have increased sodium, increased volume, decreased renin. The decreased renin is very important here. You'll see the changes in the secondary one. In the secondary hyperaldosteronism, the primary problem is decreased volume going into the kidney. For example, here's our kidney. We have our renal artery. If we blocked it due to cholesterol and clotting and all that other stuff we learned about with atherosclerosis, blood doesn't get through that. So the kidney thinks there is low volume. Hypovolemia, if you're bleeding out, you're losing blood volume. The kidneys think there's low volume. It wants to raise your blood pressure to prevent your body from dying. It needs that perfusion pressure. We got to get the volume up. So, but in this case, they're being tricked. But either way, regardless, low blood volume going into the kidney is going to increase the renin. So the renin is increased with secondary hyperaldosteronism. In primary hyperaldosteronism, the renin is decreased. In secondary, it's increased, which will then increase your aldosterone. They are both hyperaldosteronism. One of them is the high aldosterone is the cause. The other one, the high aldosterone, is a result of a problem. That's why we always say secondary is an underlying cause leading to a higher result of the aldosteronism. In the primary hyperaldosteronism, the result of the issue is with the aldosterone itself being elevated due to hyperplasia, cancer, stuff like that. And what's the mechanisms for the polydipsia, polyuria? Polydipsia, ADH is still stimulating thirst. You're going to have high sodium levels, increased osmolality, because you're having hyperaldosteronism. So sodium is high, so your ADH is still working. Hey, we need to dilute this out. Let's keep drinking water like crazy. Polyuria, when losing potassium, ADH is ineffective in the kidneys. Paresthesias is due to the hypokalemia. Hypokalemia is due to all of the aldosterone. This just explains what's going on in the kidney itself. But the end result is, due to this excess aldosterone, we're going to be losing potassium in the urine. And we get hypertension due to the increased sodium and water retention. So these are the reasons that they have those complaints. And that is the end of the case studies. If anyone has any more remaining questions, I'll answer those. Or if you have any questions about any of those cases, I can go back to them as well. I'm trying to think of anything else. Just remember all the different hormones, know the feedbacks, know when you have too much of the hormone and when you have too little of the hormone. Know that some of the complications we went over, especially the diabetes complications. Again, Addison's versus Cushing's, one's low, one's high. We didn't do much with growth hormone in those case studies, but remember with growth hormone, you got acromegaly and you got gigantism. The key thing is with gigantism, it's increased growth hormone before the growth plate closes, that epiphyseal plate. With acromegaly, it's increased growth hormone after the growth plate closes. And that's why they have different types of features with those two. Remember the different things with the pituitary gland, the different causes for those different forms of hypopituitarism. Your diabetes insipidus versus SIADH. Again, it's too much or too little ADH. Diabetes insipidus is too little. SIADH is too much ADH. The GI stuff, again, very straightforward as well. As far as acromegaly, growth hormone is not suppressed by glucose. Good to know. I don't know if it's required or not, but it's good to keep there somewhere. Okay, nodular thyroid diseases. Just put up my slides here. So basically, when you're doing your nodules, know, is it solitary or multiple? So is there one or multiple? And know, is it functional or non-functional? Those are the two things to know. Is it functioning? Is it producing thyroid, or is it not functioning? Is it not producing anything? To know the solitary versus multiple, you need an ultrasound of the thyroid to see what's going on. You can try and feel for some. Functioning, non-functioning, you need that iodine uptake test. Non-toxic, asymptomatic, no problem, no pain. Toxic will have pain. They will have nodules, multiple nodules that produce a lot of thyroid hormone. What else? Know the risk factors for malignancy with a thyroid nodule? Male sex, history of other types of thyroid cancers, radiation exposures, and then the characteristics of the thyroid. So non-toxic are going to be, hang on. Yes, non-functioning. Because the thyroid is functioning normally with the non-toxic goiter. The issue is when you get pain. If the non-toxic goiter becomes painful, that is a sign that it may have become malignant or hemorrhaged. Physiology-based questions. I mean, in the sense that I may ask about feedback loops. That's pretty much it, though. But that should be part of your when you draw this stuff out. So your feedback loops will be there. So I think part of the confusion with this whole hot versus cold thing, I was talking about goiters. When you're talking about other forms of thyroid cancers, medullary thyroid cancers, those type of things, those won't have the increased uptake. So those are going to be cold. But because I'm referring to these toxic nodular goiters, it's going to have a hyper-functioning nodule, which is why it's going to be hot. But cold nodules are usually a sign of malignant cancer, like the medullary thyroid carcinomas and papillary, which is why a risk for malignancy in a thyroid nodule is a family history of papillary thyroid carcinoma or medullary thyroid cancer. You can also have cancer of the follicular cells. So there's different types of cancers within the thyroid tissue that lead to those types of issues. So I would have to say it's a toxic nodular goiter or toxic multinodular goiter. It's the goiter that tells you it's hyperfunctioning thyroid tissue. So I hope that cleared up some of the confusion on that one. I'll pull up the GI slide real fast. But I won't ask you questions like what is digestion, what is motility, like for the GI stuff. That I won't ask, or like any of the beginning stuff. Like obviously the Z line's important because we discussed it as far as why. So it's important to what we're talking about, but I'm not going to go through it very detailed as far as the anatomy and phys of the GI system. So the motility disorder is just dumping and gastroparesis. Your peptic acid diseases, your gastric versus duodenal ulcers. The differences and the signs they get. Know how H. pylori does its job. Remember, if you have a bleeding ulcer, that means you got into the submucosal layer because that's where all the blood supply is. Remember, with Crohn's versus ulcerative colitis, one is a full thickness, one is only the mucosal layer. Know the different forms of diarrhea. We went through, reviewed that already. Yeah, that was pretty much it. Complications from those, signs and symptoms from ulcerative colitis and Crohn's. Won't be any images, as usual. So, okay, well, I haven't had a question in a while, so I will sign off for tonight. Good luck, guys. Just keep your hormones straight. Know what the pathways are. Know the signs and symptoms when it's too much hormone or too little of the hormone. And stuff like that. Okay, guys, have a great night, and I will see you tomorrow morning.